access injecting drug users to treat them and look after them?
Yeah, just to give you over a background of the situation, there are over 3.5 million people who inject drugs in the region. That's Europe and Central Asia, and tuberculosis is the leading killer of people who inject drugs and live with HIV. So that tells a lot, doesn't it? And because in many countries harm reduction interventions are actually banned, legally banned, such as Uzbekistan, for example, and Russia, you have a situation when people with tuberculosis just do not come forward, meaning that tuberculosis is a disease that needs a closed setting, and the treatment takes place in closed settings, whereas HIV is not as a similar disease as tuberculosis, so it can be treated even while in society. And tuberculosis hospitals often would not have available treatment for people who inject drugs, meaning that's ARV, or that would be, treatment for drug dependency, such as harm reduction services. So you have got a whole spectrum of legal, political, social problems, and that's, of course, social comes to stigma, discrimination, violence, because these people have been alienated from themselves. So psychologically, there's a lot of problems amongst these groups as well. So. And multi-resistance tuberculosis, multi-drug resistance tuberculosis as well, because TB is not detected at an early stage, and lots of countries in this region are from the remnants of Soviet Union, so that means that a lot of health systems are still operating in the way they did beforehand. So that means community health is more important than an individual health. That's somewhat maybe similar to what you have been describing yesterday, LYNETTE. So you have got lots of problems that just layers and layers, and becomes very difficult for organizations such as us to even get to the bits of it.
LYNETTE, perhaps if I could ask you, could you give us an understanding of the stigma associated with tuberculosis? Some of us may have an understanding around HIV, but tuberculosis has its own pocket of stigma associated with it. Tell us about that.
At current point in the research that's been done, especially from my region, we see that there's now criminalization of tuberculosis. This basically manifests in people who aren't adhering to treatment. So what happens is you present, you're given the treatment, and if at oral there is some sort of resistance and you're put on drug-resistant tuberculosis treatment, you are put in a hospital for 18 months, okay? So 18
isolated.
They call it isolation, but the way it's done, it's not really isolation. So if you're a breadwinner, a single mother, that is going to basically put you in a very precarious situation. So people tend to escape and go back home. They miss their families. They don't understand why they're being treated this way. A common occurrence in countries such as Swaziland and Botswana now is that the healthcare officials report people to the police, and people are now arrested. They are incarcerated and not isolated according to the Sarakosa principles. And these are global principles which make a lot of sense, which give us guidelines onto how to isolate people, and these aren't being followed. Currently in a country like Kenya, a lot of our partners who are doing a lot of legal assistance work have taken the government to court, because now as well people are being arrested when they do not adhere to the drugs. Why? Because they're hungry. You can't take TB drugs on an empty stomach. They are gruesome to the body. So people are being criminalized because of HIV. So that's where the stigma comes from. In a lot of communities as well, people with TB are seen to be bewitched. The communities don't understand TB that well. So now there is, I think, growing social acceptance of HIV. But with TB, people are just saying it's too much and they don't understand it. So, of course, that increases societal stigma. A lot of women who get married culturally are disinherited. A lot of them get divorced because the husbands do not want to be with this person who's bewitched, as it were.
The issue of incarcerating people for drugs, that legal framework of what we know in perhaps Western society as the war on drugs. How does that play out in Eastern Europe, and then people in prison being treated for these infections?
Yeah, we understand that in Eastern Europe as well. In fact, my country, which is Georgia in Eastern Europe, a very small country in Caucasus, has the most repressive drug policies in the entire region, meaning that for a simple smoke of a marijuana you can go to prison up to 3 to 4 years, which means that eventually you had, in 2012, you had every fifth male adult person having a criminalization record, conviction record basically, and 1/3 of that was for drugs. Whole spectrum of activities within the drug offences as it is defined by the EMCDDA. But other countries, even where drug use is not criminalized as such, you have got situations where police uses all sorts of illegal activities such as blackmailing, extorting money, just beating people up in streets, and bribery as well. Huge corruption in Kyrgyzstan, Tajikistan, Russia, Ukraine, in terms of how these situations are dealt with. As for the incarceration and prisons in particular, for example, Azerbaijan is quite problematic in that term, so is Russia and Ukraine. In none of these countries, I might be wrong actually on that, I don't want to press on it very strongly, but certainly in Russia and certainly in Ukraine, full package of harm reduction services, none in Russia in fact, because Russian drug policies for 2010 to 2020 explicitly bans even the use of a term harm reduction, and you can go to prison for under the article of glorification of drugs if you mention harm reduction in that country. And therefore none of these treatment services are available, and you have a situation in these two countries when you have such high rates of HIV among society, and that is doubled or even tripled in some cases in prisons, and then you have got co-infections indeed, and people come and go within the prison system. And the situation is that for drug use you don't go to prison for 20 years, right? You go to prison for 3 to 4 years. This is a time which is rather easy because there is malnutrition, there is all sorts of overcrowding issues and so on. And then because that's a very short period of time, when you go to prison, come out, then go again and come out, there's a certain hazard, which is the risk, which is that you carry that diseases with you. Therefore, you go to public, you take with you, then you go to prison and you come out, and then you carry it over and over. And until now, there has been no comprehensive analysis of this situation. I mean, I know Ukraine did some analysis of HIV in prisons and possible interventions. One of the professors from German university worked on it, and I know that study, but the government has not taken it on board. So there's a lot of problem. Very often things are blamed on the resources, mostly financial resources, but it's not just financial resources, it's mostly the political will. So,
tell me, is there an issue with drugs in the prison system itself?
Surely it is. I mean, no country can say that there is no drugs in the prison.
No country admits to it.
Yeah, but the thing is, again, just go back to my country, right? The president of the country in 2006 announced zero tolerance policy. That was 2006. In 1 week time, the respective laws were passed, and from 7,000 prison population, we jumped up to 24,000 prison population. And I have worked in prisons, and I have gone to prisons as an independent human rights monitor, and I have seen tremendous stuff there. I don't want to see that again in my life. So the situation is that, and then yes, they said, well, there is no the drugs in prisons. And when we spoke to people who use drugs and they had been to prisons, right? They say, yeah, that's right, because we felt like we have been in a concentration camp. We have been beaten up every single day in the morning and the evening, and then the situation that they described was amount to torture, and then there has been lots of international recommendations on that. In fact, just last word on that, in 2012 the videos came out, the footages came out from Georgian prisons, which was the prison administration raping the prisoners in front of everybody, everybody meaning quite a large group of prisoners. So to give an example how they should have behaved.
As a threat.
Yes. So, and that actually very much prompted the governmental change. We had a change of the political party in the government, in the power. So that is how big it can get. So,
but as they say, there are no votes in prisons, and it's interesting to get that national engagement from an incident so vile as that. In South Africa, you have access to medications for both tuberculosis and HIV. What is the thing that's getting in the way of getting the jump on this problem? Is it political engagement? Why is it that we are not seeing progress in this space?
I not only speak for South Africa, I speak for SADC in general. South Africa has done a lot of work, and they seem to be balancing access to treatment. The only problem that South Africa now faces is the fact that we're dealing with patent barriers, intellectual property barriers. So we are finding it more and more difficult to access affordable, safe, generic medication. And this is because we've got a weak patent system, and so activists such as the Treatment Action Campaign and Section 27 are working on that. SADC as a region is another story altogether. It varies from context to context within SADC in East Africa, but mostly it's the political will. That we also see the very same issues that I think Eka is expressing. We deal with the very same issues. Being as well or classified under middle income countries by the World Bank is not really helping us as well, because we're dealing with a lot of social determinants that are impeding progress. Not only is it stigma and discrimination, but it's also actual access to healthcare for key populations, let's say. Vulnerabilities brought around by issues such as patriarchy that are very heavily entrenched in our cultural systems. So we still have a long way to go, I'd say. And we're not really seeing the reductions that we're expecting to be seeing because of the lack of respect of human rights and understanding of those human rights principles that can actually assist us in progressing on both epidemics.
Eka, Australia, as you know, was world-renowned for its HIV response with harm reduction process and injecting drug exchanges for needle programs. You must be looking at this very closely with your visit here to AIDS 2014, but it would take a monumental shift in political willpower for something like this to be introduced throughout Eastern Europe. How urgent is this necessity?
There are a few levels of answer here. We know that globally there are less than 40 countries that have needle and exchange programs, and majority of them are in Western Europe. We also know that, 40 was the OST, that's the opioid substitution therapy. Less than 10 is the needle and exchange programs.
Which is extraordinary.
Yes.
That alone is extraordinary.
Yeah, exactly. And we also know that even though the UN Office on Drugs and Crimes has been very vocal, in fact, in promoting the harm reduction services, maybe not naming them as harm reduction, but certainly promoting the 15 interventions as it is now, that was designed jointly by UNAIDS, WHO, UNDP, and the UNODC offices. Countries do not have a political will. That basically comes with the security aspects, because when you talk about prisons, especially, you have a competing interest of health and security, and very often security prevails, as we have observed. And so how do you deal with it?
Sorry, why is health and security competing interests?
Because when you talk about injecting drug use within prison environment, number one, drugs should not be reaching inside the prison, and it's reaching, therefore something is going wrong with the security.
Now I understand.
Number two, you need a health response to the drug use, which means that well, okay, security failed, now health should go forward. So what's going on? So that even if you meet with the prison administrations, you will see that that kind of competing interest is always there. Very often, the Ministry of Health is less vocal than Ministry of Interior, the Prosecutor's Office, the Ministry of Justice, and so on, the main ones that design the criminal justice policy. So that's kind of how the whole kind of the policies are designed within country context, and the same in societies. I mean, to bring you an example, we have been Kyrgyzstan, for example. It's a Central Asian country, and very much kind of spurred, and there's a widespread of drug use in this country. And even though they were very resistant towards, to introduce the harm reduction services, after realizing that actually this may be a good idea with the fund of Global Fund, which I often kind of criticize, because what's going to happen when the Global Fund leaves? Because this is not a rich country, and yes, today they are very inclined to do that, but what's going to happen tomorrow? So we don't know what will happen. That's one, and therefore, because Kyrgyzstan has a very good scheme of available OSTs and NSPs both in society and in prisons. So there is now the so-called Angas 2016 that's coming up, and that's the UN General Assembly high-level talk on drug policies. It's going to happen in 2016. We expect it's going to be in May. And there's a lot of preparations by non-governmental organizations, either regional or international. There's a lot of mobilization, lots of talks. In fact, I just left a meeting, strategic planning meeting on that. Lots of drug user groups involved from all over the world, and so on and so forth. What you see, though, when you talk about drug policies is dropping small issues such as harm reduction, treatment, access to treatment, TB, HIV, and so on. And the reason for that is that drug policies itself, it's a large policy, right? It comprises many different aspects, including criminal
most
justice.
of it legal, and not enough of it health.
Yeah, exactly.
Yes,
although we know that drug policy is nothing but the composure of health and criminal justice policy. It's a fusion of it, right? Both of these policies. So, and then we have a lot of even among then you have got development NGOs really worried about, for example, coca bushes in Southern America, and so on and so forth, right? You have got all these again competing interests. So how do you make sure that harm reduction stays on the agenda, and actually it becomes instrumental point in reforming the drug policies in countries? And I have to go back to Georgia again, because it's an interesting country. It's a country that likes to experiment a lot. And we had a hepatitis C problem, 20% prevalence among society and 60% prevalence in prisons.
20% in general population?
Yes.
Wow.
And 60% in prison. So now I have to imagine the levels of it, right? And you have to also imagine that I mentioned the sudden prompt of prison population from 7,000 to 9,000 to 24,000, and we had legal cases being taken to the European Court on Human Rights, on HCV, and there was hundreds and hundreds of cases being sent to the court, the European Court on Human Rights, and the judges said they issued just a blanket statement, the decision saying, look, we can't deal with this. Do something with the system, because it is a systematic problem. It's not just one case of denying an access to treatment. You have got a system problem. People are healthy when they come to your prison, and then what you do, you put them, I don't know how to say.
You lock them away, and they come out with these.
And then therefore they spread the thing in society. Now I have to mention.
Yes.
With the help of drug policy groups, with the help of health groups. There has been tremendous support from Open Society foundations as well, and the Global Commission on Drug Policy, which Kazachkin sits on. He is the former executive director for the Global Fund. It has been possible for the government to introduce free hepatitis C treatment in prisons. And there is an certain discounts in society, because it cost about, to treat HCV, it was about $30,000, and normal people can't really afford it. I mean, honestly, it's quite a lot of money for people of Georgia, because it's a very, very poor country. And there's a lot of discussions now. We expect that it's going to go down really immensely, up to $2,000 to $5,000, which is going to be an achievement.
So you're not there yet, but you're nearly there.
So we have a political will. We have Minister of Justice 2 weeks ago again to mention. We had a meeting in Geneva, and they are very open. They say we are doing anything. It's a process in planning. The NGOs are involved. We have international experts providing expertise. We have pharma companies being part of the whole discussion, and the government is making a generous contribution to what is a political move on that. So, and it's not just hepatitis C, it's not just drugs, it's a combination of things.
Lynette, this shift in political will is clearly at the core of getting on top of these issues. What role does civil society play in that, from both a local perspective and a global perspective?
It's a very interesting question, because I think throughout this conference, I've heard a lot about how civil society needs more funding in order for civil society to be better service delivery implementers or custodians. And that's not the role of civil society. I always fight with UNAIDS around this. Language is very critical, because in a lot of our countries, we have become the service providers. So what's the role of government? Because you cannot be a service provider as well as a monitor at the same time. Within a lot of our countries, what we started doing is doing a lot of accountability work with our governments. While we're very, I think, grateful, especially as Africans, that the Global Fund came through when it did, and programs such as the PIPFA and all of those. What those programs have essentially done now is, I think, the same thing that ICA's worried about their region, is that they have spoiled our governments to such an extent that majority of our health programs are funded through the Global Fund or through some sort of external donor. While our presidents are buying jets, going on holiday, chilling, there's no problem on earth. We as civil society currently are holding those governments accountable, because Africa needs to really be at the center of its own response as donors start pulling back. We're currently working with the African Union. It's received a lot of help in coming up with an African roadmap. The African roadmap has basically got a strategy of how African countries need to start funding the response, and that is basically, I think, the crux of the accountability. That is the crux of the leadership that is required in order for us to see Africa taking care of its own problems. Because at current point, we really are seeing organs such as the Global Fund actually being very precarious because of various reasons, including the fact that not all our countries are going to be funded with this new funding model. We are in a lot of trouble, and somehow it's like we're waiting for them to say, you did not get the funding, before we react, and we're very worried about that. So we're doing a lot of advocacy with national level governments.
The Global Fund has been burnt too many times in the African region, though, and we see a level of ownership in China and them taking ownership of the issue, and the Global Fund being able to happily let go and spend those resources elsewhere. From an observer's point of view, I share your frustrations. What level of accountability can ensure that this doesn't continue to occur, or that the monies are channeled to where they're needed?
Unfortunately, that's...
And who's policing this, you know?
Yeah, that's a catch-22, to be honest, because at current point, we're like, we are drug addicts, or we're addicts to the Global Fund. Our health systems are, right? Because the people that suffer in the end are the people on the ground. You can go to any African regional country and ask any common man on the street, where do you get your drugs? They're not going to say the Global Fund, they'll say my government. Okay?
Of course.
So
makes them look good.
Exactly.
Yeah.
So there's no connect that actually these funds are coming from an external source. They're not coming from my hard-earned money, because I pay taxes as a citizen. So of course the government should give me health care, but that's not the reality or the truth at all. So at a SADC level, what we're seeing is government saying to us, okay, we want to come up with better financial accountability mechanisms. So how do we do that? And they're starting to ask us as civil society. So we are also considering things like, financial transaction taxes, national AIDS funds, and all these other really innovative financing mechanisms that other civil society, even within a European space, a lot of our colleagues are doing globally. And we try to basically emulate that at a local level. The only sadness with that is the fact that there's nothing in the interim, right? We have nothing currently in the interim. Secondly, there's so much corruption. Like globally there's corruption, but ours is so glaring, it's actually quite disgusting and shameful at times.
And we look at that from afar and go, how do the people of this nation allow this to occur? Because it seems so obscene.
No, true, because I mean, as well as I said, we're cultural people, so the president is king. So what you do, you don't hold your president accountable. It's not allowed. Otherwise, it's un-African to hold your leaders accountable. What you're supposed to do is swallow and say, yes, master, it's okay. It's only as a civil society trying to reinforce these messaging through communities in the most respectful way as possible, and using the rights-based response to say, well, really, at the end of the day, you're going to be screwed and they're going to be taking their kids to private facilities. So I think our advocacy is slow in reaching them, but with the likes of TAC and what's happened with HIV, this movement has galvanized that mental shift in communities to say, actually, you can fight for your rights. We've done it before. We've shown you that it can be done. Otherwise, there are going to be too many casualties in the next round for us to even try to then react. We need to be proactive. So we're hoping that with these mechanisms that we're trying at a local level, we will be able to start taking more responsibility and national ownership for our response, increasing funding for health so that we can start looking at our own health response and ensuring that Africa itself actually starts increasing its manufacturing capacity. I think India is tired of us.
Yes, we are speaking with LYNETTE MABOTE from South Africa. She is the Human Rights Advocacy Team Leader at the AIDS and Rights Alliance for South Africa. And also with us is IAKOBISHVILI. That was shocking. I apologise, Eka. Eka, your work throughout Central Europe and Central Asia and Eastern Europe, 30 years on from the discovery of HIV, and this issue that is emerging and continuing to grow within Eastern Europe, it must be a frustrating thing for you as a human rights advocate to be, I guess, having conversations around these things that for some countries we would have thought were taken care of, or should have been taken care of, or are taken care of globally in some framework, but just not implemented.
Yes, it's quite correct. Everywhere in the world, the HIV rates are decreasing, whereas in Eastern Europe and Central Asia, it's actually quite opposite. And that increase is mainly driven by injecting drug use again. The thing is that I see quite a lot of similarities what LYNETTE actually was mentioning in terms of people not really knowing how to hold the governments accountable for many issues, and this is one of them in terms of having an access to treatment. I do a lot of online trainings for people who use drugs or live with HIV or are sex workers, different communities and in different countries in the region. And it would be probably quite funny for people outside that region to see kinds of discussions I have with these groups. For example, what is human rights? So I'm a sex worker. If police slaps me in the face, I deserved it, don't I? So what kind of right do I have? I mean, I am a sex worker, I have no rights. And then you have to explain them what human right actually means, that you are not deprived of human rights because of your social status or because of your HIV status or whatever. And you have to explain them that, well, those human rights are given to you by nature. You have them because you are a human being. And I have those discussions. And then sometimes we even go to the philosophy, and it's quite amusing in times, honestly, to see where these discussions lead us. And then we talk about the laws and the constitution, why they need human rights, and people tell me, well, look, I'm bored with you telling me how many rights I have when police stops me, because I always give you have got 3 basic rights. And they say, well, yeah, but just tell me, why do I need them? I tell that to police, he's gonna even beat me up more. And I say, well, look, you need them because, one, it's a general knowledge, and knowledge is good. Does not matter whether you use them or not. Knowledge is good. That's a very basic thing, believe me. And then I say, well, you don't need to tell the police straight away that you know your rights. What you need to do is very slowly and clearly observe how police behaves, and just very slowly, follow the procedures, and then try to make it as right as possible for your conditions, depending on your circumstances at the time. And then they say, well, yeah, but it doesn't really matter still. But you know what? It helps to mobilize them. It helps to increase their knowledge about, for example, why hospital managers need to accept them in hospitals when they have HIV. Because in most countries, in Eastern Europe, Central Asian region, you have got laws which says that if you are a drug user, you can't access to HIV services. So you have to either lie, or if you still get the HIV services and they discover that you actually inject drugs, they will kick you out. So that's quite a dichotomy in a way, yeah.
But that only perpetuates, I mean, this is my privileged position commenting, but we all know that only will perpetuate the transference of the disease.
That's what we know, but tell that to a hospital manager or a nurse.
But a hospital manager should know that better than you and I.
Well, that's what we imagine. That's why we say that. That's why it's so needed that the curriculums at the national level, not just the police training curriculums. We work, with police academy, so that they.
And this is more than just basic sex education.
Yeah. It's not even a sex education. It's just it's a common sense we would understand. But the thing is that, again, going back to the Soviet kind of a generation thing, is that in lots of these hospitals, people who work there, their education comes from Soviet times. We like it or not, that's how it is. And Soviet style of education was very regimented in a way. It was, they still use the word narcology, which is kind of a combination of addictology and some other social. It's basically medicalization of drug dependency. It's medicalization of a severe medicalization that includes psychiatric and a physical kind of dependence. But they look at it from narcological point of view, and they say we don't accept this new research. Like Rush, for example, we don't want that.
The hangover from the collapse of the former Soviet Union, has that really impacted this space greatly for those Eastern countries?
Yeah, I mean, some countries, certainly. I mean, some more than others,
Yeah.
of course. I mean, and again, to go back to my country, it's a very small country, so it's easily manageable. So it's like less than 4 million people. So
It could become the world's best practice case study.
yeah, that's why I say they love experimenting,
Yeah.
and they like to compare themselves to other successful nations. But there's something always going wrong there. So, but if you take Ukraine or Russia, they're massive countries. I mean, geographically, honestly, to go to the nearest, from one prison to another. I mean, just taking again a prison example in Ukraine, you might want to travel for 3 to 4 days on a train. And can you imagine who is going to go there? I mean, the prison administration would own the world there. You know, they would own everything.
In fact,
there.
it is the world as they know it.
Yeah,
Yeah.
exactly.
Yeah.
So, and that Soviet education is the whole generation, and then there is not anything being done to enlighten them on, more progressive kind of thinking that has become. We have moved to 21st century. There's new discoveries in terms of treatment of TB, HIV, HCV. In fact, they may think that TB is not curable still. So, I mean, it's just a joke, but still, I mean, and then most of my cases that are human rights violations, they are very much related to how hospital staff treat people who use drugs. That's not even stigma, that's a structural violence and structural discrimination that needs to be looked at that structural way, meaning that the government has to do something. It's not changing societal attitudes and the awareness amongst people, it's a structural change that has to come.
It's not cultural,
from the top.
it's structural.
Yeah. Well, sometimes structural becomes cultural and vice versa, but unless you do things from both sides, the change is not going to happen. So,
Lynette, Eka mentioned the need for education around what many of us would consider some base level understandings of what we're all entitled to. Does this come back to your argument for mainstreaming human rights? And what does that mean?
I think human rights is according to us, or the way that it was introduced to us, it was very Western in its conception. So as I was saying in my presentation yesterday, we very community orientated, right? There's no individual. So Descartes, I think therefore I am, doesn't exist in a lot of.
But there is a
societies.
hierarchical structure.
Yes, of course. But as much as it's hierarchical, it's very much community exchanged, right? So we'll say Ubuntu. I don't know if you've ever heard of Ubuntu. Ubuntu is our philosophy. I am because of you, because of us. So we're together. Umuntu gamantu. So because you can't be an individual, it's very difficult for you to claim your rights as an individual. You have no autonomy in that sense. And if you were to then express the fact that you had autonomy, then you'd have to go up the hierarchy to report.
Get it right? Yeah. Okay.
Exactly.
Yeah,
then only the hierarchy would say, yes, you do have rights. And then, yes.
Yeah.
So that's what's happening currently with a lot of women.
But that could be worked to the advantage, surely.
Well, that's what we're trying, right? But I think that's why we're saying we're fusing human rights with culture, so that it makes sense to our leaders. When I mean our leaders, I mean at a community level. So that they understand how important it is to treat women with respect, to stop the female genital mutilation, to respect LGBTI people and sex workers because of those concepts. So that's how we hold them accountable. It was very sad because we've just gotten, there's a case that's ongoing in Lesotho, which deals with female primogeniture. Women not being able to inherit chieftaincy by virtue of being women, right? So of course, it's discrimination. Okay, it's in the face of it, it is. But a colleague of mine who works, who's one of the lawyers, was saying to us, well, it was very funny to the claimants and how they went through 5 rounds of lawyers. The first 3 they went to, it was like, no, you've got no case, you're a woman. That's of course you can't inherit. Like, what is this? You've got no case. The law's there, right? Like,
yeah.
So even at that level, the appreciation of human rights is not there. This is why we need education to start mainstreaming human rights, because if there's no appreciation for it, there's no understanding for it, therefore there'll be no implementation of human rights programming in our countries.
And they can only be universal if they're accepted on the same level universally.
Exactly. Yeah. And I think that's where the disjuncture is. It's like, what, Universal Declaration of what? I don't know what you're talking about. No, you know, it's a piece
And then there
of
are countries that just ignore it. Or seemingly.
Completely, yes. I mean, a country where, I mean, it's very funny. I represent my organization at the African Commission for Human and People's Rights.
I wanted to ask you what the difference is between human and people's rights.
I'm not actually sure. That's quite an interesting question, and I think it's also entrenched in Ubuntu, right? The human and the people. We need to understand that there are two separate things, and I think that's why, naively, I think it's just like from my own personal opinion, I think that's why they separated them. But it's an organ of the African Union, all right, that's supposed to report and basically take care of human rights issues. And very funnily enough, the offices of the African Commission for Human and People's Rights are in Banjul, West Africa, in Banjul, in the Gambia. The Gambia's got the worst human rights record ever in the entire region, and I don't know. I find it very difficult that we could go to a place or take people's human rights to a country where, when people are sick, the president basically is the country's traditional healer. So you're given herbs for your HIV status, and it's been happening for a very long time. And if you're not healed, you get basically isolated to an island. And this is like common practice. People are just like, yeah, it happens. So, you know, you shouldn't report. So it's a form of criminalization that's not necessarily documented in statute that happens in a country. And that's where we have the African Commission for Human Rights. So where do you think rights are based? I mean, rights are very abstract, I think, to a lot of countries. And it's not only in Africa. I think ECO would agree. They're very abstract things. And we've now started appreciating the fact that because of their non-universality at current point where we're sitting, it is really critical for us to appreciate the fact that I can't go into a country where there's female genital mutilation and say to people, fight for your rights, over a donor presented period of time and expect to get impact, because it takes a very long time to educate people. It's like a whole mind shift that
becomes the cultural change. Yeah,
exactly. The mind shift is required, and that's where you actually see real change, right? And real change takes time, but our donors do not have the patience. They want impact tomorrow. So as NGOs, we struggle quite a lot to see that change in the period of time that is required.
Eka, you mentioned before that there will be a UN Congress around drugs in 2016. We've known how these diseases get transferred amongst key affected populations, including injected drug users, for so long now. We knew from day one almost. What is it that can be achieved in 2016 that we don't already know? And how can that Congress see the change in your region that is desperately needed?
Well, mainly, I think the need for the call for the August 2016 was very much driven by South American kind of developments. As we know, Uruguay kind of legalized cannabis, and that has spurred quite a lot of fear amongst states at the CND, the states that sit at the CND. Just to explain that CND is the Commission on Narcotic Drugs. There is a functional commission under ECOSOC, which is itself a body under the General Assembly. So the CND sits in Vienna, and then it convenes once a year in March. And countries gather once a year, basically to talk about drug problems and adopt resolutions. They are not really adopted; they are agreed. Sometimes it takes nights and nights for countries to come to a consensus. And if you have countries like China and Russia on the Commission, it makes even more difficult to agree on things. And so the country saw that the change was coming. There's quite a lot of growing movement, in fact, for deregulation rather than the legalization of drugs rather than prohibition. So there's a whole dichotomy of prohibitionists versus legalizers. Or
well, in the US, we have no more room to put prisoners, and we see them capitalising on the sale of drugs and taxing them accordingly at a time when governments desperately need money and financially challenged. This is going to be case studies that are rolled out throughout the world, I think, as they see the financial benefits of it. But how will that play out in your region?
So basically that's very much kind of driven by all these responses, plus USA, which is itself a very interesting example in terms of incarceration of people for drug-related offences and stuff. In my region, that's going to be, again, just go back to my previous point on harm reduction. What we are trying is that very recently we have been fortunate enough to be chosen by the Global Fund to be given over $6 million to execute a program, which is an advocacy program in the region to basically advocate for the transfer of the harm reduction funding from donors to the state. So there's going to be a lot of immense work to be done to basically persuade the governments to take up some things. $6 million looks very big number on the paper, but for
really.
The region, and it's quite big for us as an organisation because we are a really small organisation. But it is not really that much for the region and for the countries.
How many countries are we actually talking about that you'll be focusing on directly?
Under this particular Global Fund program, we have 5 countries, which is Kazakhstan, Tajikistan, Georgia, Moldova, and Belarus, and they are
very different
very
targeted
different,
campaigns are needed.
Absolutely. And they were chosen by transparent competition, so we did not pick them up. So the process was started from the grassroots. Actually, the whole project proposal was designed from the grassroots, learning what was needed and so on and so forth. It's quite a tedious process that I won't bore you with, but these are very different countries from one to another. But so just to make sure that this is a 3-year project, and what we are trying to, how we are trying to link that to August 2016 is to push for the call. There are different asks that the NGOs have put forward for the Angas, and we are actually joining the Harm Reduction International asks, which is basically formulated in 2, which one is the funding for harm reduction services, and the other one is to make harm reduction key for drug policy reform. So for the region, that's mostly needed, and then the rest of the framework of human rights and documenting violations, that is something that needs to be embodied within that harm reduction drug policy stuff, because it's a technical aspect, as we see it, that makes policies just, transparent, and better. So main thing is to actually mainstream, incorporate the principles of human rights within these calls.
One last question for you as we wrap up. What can we as the global population do to, I guess, support your cause? And you've got a very big challenge ahead of you to get even this conversation on the table. But what can we do as a global society?
Well, I think as the more people mobilize around these issues, the better, really. And I believe in transparency, cooperation, and teamwork. And for the moment, Eurasian Harm Reduction Network is. I don't want to promote my organisation.
Please do. No, I'm happy for you to do that.
It is an organisation that incorporates people who use drugs. We have staff who are themselves, either former or current users. We act as a secretariat for Eurasian network of people who use drugs, and And we believe that the more we become participatory in terms of, the more we hear the voices of people who are most vulnerable and affected, the better we can design our responses to the policies, the bad policies as they are. And I think in terms of the global community, I don't think that global community is something separate from the local community. So, for example, if you do something in your own country or in your own respective constituency, that's good for me, because one, it's learning and experience sharing. Two, I can become a partner and we can do things together, and therefore we can join the actions and so on. I'm very optimistic today. So.
Lynette, the same question to you. What is it that we can do to create further understanding and help push this forward?
I agree with Eka 100%. We were actually talking because SADC and East Africa and Africa in general is actually dealing with, there's a growing population of people who use drugs. It's only at the coastal areas that we've got injecting drug users, but like within the populations, it's quite a growing problem. So we're also going there in terms of the problem, so we can learn from them how to start doing the advocacy. And I think we need global solidarity on these issues. It's not only an African issue, and we can't keep segmenting ourselves or separating ourselves or isolating ourselves. We're a global nation and we all suffer. When one suffers, everybody suffers. And that's the thing with what happened with TB, right? It was very much, okay, no, you only get it in Africa. And then people came to work in Africa, flew home, and there are a lot of stories that have been said, especially around MDR, TB, and where it came from. And it just shows that because we're a global population, we're migrants as well, right? The world is so small that we can't really sit in our corners and hide anymore. So the best way to do it is actually to hold hands, work together. And civil society has done tremendous, amazing work. First of all, in bringing up and in calling for organizations such as the Global Fund. And now as we hold our own governments accountable, I think it is key that we hold our hands together and support each other's agendas.
Thank you both so much, to Lynette and to Eka. Your insights have been challenging but inspiring. Keep up the great work, and thanks for joining us today.
Thank you for having us.
This has been the Global Village Connect AIDS 2014 webinar series. I'm Dean Beck. Thank you for joining us. Thank you so much.
Thank you.
Thank you.
Thank you.
Absolutely amazing. Thank you. I don't know how you do it. Really? Absolutely amazing. Thank you very much.
There's a session you must come to.
My session at 11.